Good morning. I'm speaking on the above title. We want to review the strengths, weaknesses, and opportunities in the context of Swaziland in terms of treatment as prevention. Swaziland, as you may know, is a small country in terms of population and landmass, between Mozambique and South Africa. We have a population of 1.1 million. About 75% of our population live in the rural area, yet we are considered as a low middle income country. HIV prevalence has been one of the highest in the world, with 26% among the 15 to 49-year age group. In terms of our ANC mothers, we have a prevalence of 41% in our Sentinel studies. It is estimated that about 202,000 of our population will be living with HIV and AIDS this year. And the same spectrum projection indicates that new infections will be around 13,000, which comes to about 110 new infections per month. The same projection also indicates that 96,000 of people will need ARV this year. We have a very good ART program that has put about 72,000 of the population on ARV as of December last year. We are concerned in terms of issues of new infections and transmission. And most of our policies have aimed at addressing this issue, like the National Multisectoral HIV/AIDS Policy and the National HIV Prevention Policy. They are saying we can look around and seek for evidence-based information that we could apply to see to the control of new infections. So with this background, the question is, in terms of treatment as prevention, what is the standard, what is the stand of the country? For us to answer this question, we tried to do some desk review, do an analysis of our strengths, weaknesses, opportunities, and threats. We looked at local operational research findings, like the loss to follow-up study we did in 2010, the rapid ART assessment in 2011. We also looked at program data and clinical data from all the sites, which we do on 6-monthly basis. Then we looked at other evidence, like our male circumcision uptake, how is it? ARV and laboratory supply, continuity, support system, these are the things we considered. The purpose of this is to assess the current national and programmatic context of the country vis-a-vis the possibility of implementing treatment as prevention in a resource-limited setting like ours, that is faced with huge burden of HIV prevalence. Then we also wanted to find out, are there some priority group, population groups that we can use initially to implement treatment as prevention? And our findings include that in terms of strength, we have a fully functional ART program with a structured pre-ART system. We have decentralized our our HIV care services in 111 sites out of 264. We have also implemented next-late ART initiation in 79 sites, including public health units, TB clinics, and primary healthcare settings. We have integrated our TB and HIV services. These we think are strengths. Then also we have a very supportive Ministry of Health and committed political system. As most of you have know that in 2006, our king declared HIV a national emergency. And since then, the government has been committed to supporting the program. We are also committed in zero new HIV infection. We have made strides towards virtual elimination of mother-to-child transmission. Procurement of ARVs and other lab consumables has been a focus for the government. Even as we are here, we've already submitted a proposal for the budget for the 2012-2013 period, as you can see in the graph, including not just the ARVs, but drugs for Kaposi's sarcoma, the cotrimoxazole, and isoniazid for preventive therapy, and the same with laboratory consumables. And the government is really doing something about approving this. Another of our strengths includes the ART coverage, which has been rising over the years. And in 2011, December, from the M&E report, we have up to 80% ART coverage. PMTCT is another area of strength. In 2005, out of the 12,000 exposed infants in the green bar, about 5,000 of them were infected. But over the years, we put systems in place that in 2010, we'll be able to avert over 3,000 new pediatric infections. And we are moving forward to see that maybe by 2015, we should be able to head towards virtual elimination. Community participation is another area of interest. In door-to-door campaign that we did in 2010, 90% of the people we approached actually accepted to be tested. And this we feel is an area of importance in terms of treatment as prevention. Also, the SHIMS study, which is Swaziland HIV incidence measurement survey, is an area that also used community testing and reported high uptake. Active participation of community leaders in community dialogues, male-focused health days have been noted, and we can leverage these in issues of treatment as prevention. Involvement of other community members in healthcare delivery, community expert clearance, rural health motivators, and ordinary caregivers is also a strength. Among our weaknesses, we noted low provider-initiated HTC uptake, especially among our patients in the OPD and in the wards, which we estimate is maybe less than 25% uptake. Then late enrollment into ART care among eligible patients. You could see that though our baseline CD4 count is rising from 130 up to 190, but we are still below 200 at baseline. And we've noted a poor health-seeking behavior among our male population. The baseline CD4 count that we checked, comparing the males and the females, indicate that males are lagging behind the females at a ratio of 108 to 143. Low ART acceptance also is noted among our pregnant mothers. Most of them prefer to take up the prophylaxis instead of full heart. So those that currently accept heart stand at 44%. Also, among the HIV TB co-infected clients, we could put only 52% of them on ARVs. Another area of concern is issue of linkage to HIV care. As you'll see from the graph, the blue bar on the right, these are different test points. The blue bar on the right indicates people who tested positive. Out of that, the next bar, which is green, indicates those who are referred to HIV care. So the referral is not the issue because it's almost 100%, but the pink bar on the right side, extreme right, indicates those who actually reached the treatment site. And that is an area we have a problem because linkage stands at less than 40% among our referred patients. Amongst our opportunities include a program that is receptive to new interventions and evidence-based international guidelines. Like since 2010, we've been using eligibility criteria of 350 CD4 count. Also, we have integrated tenofovir in our first-line regimen. We have also taken up male circumcision as an intervention to prevent new infections of HIV. Collaborative implementing partners is another opportunity. PEPFAR-funded HTC expansion. CHI is sponsoring health system strengthening project through MaxArt. MSF is working with us in terms of TB in the country. We also have mentioned the high home testing uptake, and we feel that this is an area, if we could repeatedly do campaigns within the communities, we could also leverage this as an opportunity. Fear of stigmatization. A lot of people don't want to be sick and lose weight and miss jobs. We are feeling this could be an opportunity for a pre-symptomatic ART initiation, and this could also advance treatment as prevention. In addition, we have a very active and participatory people living with HIV organization. How can we use them? Can they be used as people who can now discuss with communities and tell them the advantages of treatment as prevention? Our ANC prevalence, HIV prevalence among ANC mothers has been high. It's been rising, but for some years now, it is stabilizing at a level of 40, 41%. And we could use this as an evidence that ARVs work. Then we can now use that and do some campaign in terms of option B or option B+. Other opportunities include new strategies for patient follow-up. We have developed a new SOP in terms of linkage to care retention in HIV care. We are, at this stage, trying to orient the facilities on this SOP. Then patient appointment reminder system is another intervention where we send out SMS to patients a day or two before their appointment so that they remember to keep the appointment. We also track our patients using phone calls and home visits. Community expert clients and other community-based organizations also attend to our patients in terms of follow-up. We have a biannual review meeting where all the ARV sites in the country meet. Actually, by 2 weeks' time, we are having the same meeting where the doctors meet, and we now look at what are the facilities doing, what are their performances, what are gaps that needs to be filled. Then we share best practices among the sites. And we feel that this is also an opportunity that can be used to discuss issues and implementation of treatment as prevention. There's what we call the leaky cascade, which are gaps in the continuum of HIV care. In terms of testing, what are the missed opportunities? Positive preventions and linkage to care, efficient pre-ART system, ART for all eligible patients, and retention in HIV care. We want to look at these areas and see where are we lacking behind? What can we put in place? Already we have some groups that is made up of practitioners and partners that are looking at this area. The purpose is to close the gap. Threats include the current financial, economic situation, both nationally and internationally. Drying up of the global fund allocation to countries is an area that may impact on treatment as prevention. Programmatic challenges may include sustaining supply of laboratory consumables, weak patient follow-up system, which we are trying to address anyway. Then we have noted that the M&E lags behind the decentralization effort of the program. Then we did a study, HIV drug resistance study, in 2008, and there's some evidence of emerging drug resistance. But the problem with this study is instead of lasting for 12 months, it extended to 3 years. So the evidence we are looking at, we are taking it with some caution because of the lapses in the duration of the study. Social issues like weak treatment support system may affect adherence, and low disclosure among immediate families may compromise family support for people who are on treatment, either as treatment as prevention or generally. Poverty is high amongst most of the African countries, as it is in Swaziland. A high rate of multiple concurrent partners, that's an area. So we are saying, for us, how do we define a couple, given this multiple concurrency? Clients' preference to alternative medicine is something that is known in Africa, and it is also present in Swaziland. Another threat that we've seen or noted is adult retention in care. It goes down over the years that by the 5th year, we are less than 40% in terms of retention. So in conclusion, we ask ourselves, what can we say in terms of treatment as prevention? And we are saying that resource-limited settings with high HIV prevalence, like our own setting, could really benefit from treatment as prevention in controlling the transmission of new infections. However, systems challenges such as leakages across the continuum of HIV care must be critically evaluated and addressed for us to maximize the benefit. Also, very importantly, is to identify additional sources of funding to support treatment as prevention. So this is our recommendation, that we develop a national framework to guide careful implementation of treatment as prevention. Actually, as I speak, we have developed such a framework, and we are waiting for the ministry to finalize it. This is to avoid sudden overwhelming of the health system. For early intervention, should there be any unexpected events arising. Then to address program challenges along continuum of care so that we maximize uptake and retention at current eligibility criteria. To identify new and sustainable sources of funding for treatment as prevention. To identify critical areas for phased implementation, like discordant couples, pregnant women, and other such groupings. Then, before we now talk of new CD4 count threshold. And finally, to work in collaboration with international partners and people living with HIV and AIDS. Thank you.